The syndrome of inappropriate antidiuretic hormone secretion involves the continued secretion or action of arginine and vasopressin despite normal or increased plasma volume. The resulting impairment of water secretion and consequent water retention produces the hyponatremia with concomitant hypoosmolality and high urine osmolality that are the hallmark of SIADH. The key to understanding the pathophysiology, signs and symptoms, and treatment of SIADH is the awareness that the hyponatremia results from an excess of water rather than a deficiency of sodium. The pathophysiology defines vasopressin, or antidiuretic hormone, a hormone produced by the posterior pituitary to help control fluid homeostasis. The hormone increases water reabsorption in the distal nephron, producing a concentrated urine and diluted plasma. Vasopressin release is stimulated by the following: increased plasma osmolality, decreased blood volume, decreased blood pressure, stress, and certain drugs. Vasopressin release is generally inappropriate in the presence of normal or low plasma osmolality and normal or high blood volume and blood pressure. In such cases, the water inappropriately retained by the kidneys ultimately causes dilutional hyponatremia, in which the total body sodium and thus extracellular fluid volume are normal or near normal. However, total body water is increased. Some symptoms of SIADH include low urinary output and high specific gravity, hyponatremia, nausea and vomiting, tachycardia, hypertension, weight gain, and fluid volume overload. These symptoms are those of hyponatremia, which mainly involves CNS system dysfunction and generally occur when the effective plasma osmolality falls. Symptoms can be subtle and consist mainly of changes in the mental status, including altered personality, lethargy, and confusion. As the serum sodium falls, stupor, neuromuscular hyperexcitability, hyperreflexia, seizures, coma, and death can result. Coma and death can even result in more severe complications.
Here are the diagnostic tests utilized in deciphering whether a patient has SIADH or not, as well as rule out other possible causes of the imbalance. These tests include serum osmolality and serum sodium, urine sodium concentration and osmolality, the renal function test, including BUN and creatinine, a random blood sugar test, a thyroid profile, a serum cortisol, a serum potassium, bicarbonate, and chloride, as well as a fasting lipid profile, and a liver functions test. Clinicians must also rule out hypothyroidism and adrenal insufficiency before labeling the patient with SIADH, as well as further tests are required to find out underlying causes according to history. Patients with long-standing smoking history, weight loss, or pulmonary symptoms must have a chest X-ray and CT scan to look for and rule out small cell lung cancer. Also, note that renal function test and random blood sugar test are necessary in order to check for hyperglycemia and uremia, as these are potential causes of pseudohyponatremia. On the right side of the slide is another way for detecting SIADH. While studying lung cancer patients that presented with signs and symptoms of SIADH, endocrinologists William Schwartz and Frederick Barter made a clinical criterion in 1967 for SIADH, which is still valid for use today. This includes a serum sodium level less than 135 milliequivalents per liter, a serum osmolality less than 270 microosmoles per kilogram, a urine sodium greater than 40 milliequivalents per liter. This is due to ADH-mediated free water absorption from renal collecting tubules. Next is a urine osmolality greater than 100 milliosmoles per kilogram. The absence of clinical evidence of volume depletion, such as normal skin turgor or blood pressure within the designated reference range. Next would be the absence of other causes of hyponatremia, such as adrenal insufficiency, hypothyroidism, cardiac failure, pituitary insufficiency, renal disease with salt wastage, hepatic disease, as well as drugs that impair renal water excretion. And lastly would be the correction of hyponatremia by fluid restriction. The following are some treatments that are implemented in the management of SIADH. The usual first-line therapy is fluid restriction, which is typically limiting the patient fluid intake to about 1 to 1.5 liters per day, and then titrating down accordingly per doctor's orders. Next is to eliminate the underlying cause of the hyponatremia. This can include several different types of cancers or a medication that may be causing it, in addition to several other possible reasons. Lastly, if the symptoms are severe, the administration of 3% hypertonic saline solution can be given. However, the change in serum sodium concentration should not exceed a correction rate of approximately 1.3 milliequivalents per liter per hour.
Here are some nursing considerations and interventions for SIADH. First, the patient would possibly be placed on fluid restriction down to 500 to 1500 milliliters per day as ordered. If the hyponatremia is severe, it is anticipated that fluids would be restricted down to 500 milliliters per day. Next, a sodium replacement would be provided intravenously or orally as ordered, and it is to be expected that the sodium correction would be done slowly to prevent complications. Lab specimens would also be obtained to test serum electrolyte and osmolality levels and urine sodium levels. If the patient is receiving diuretics, it is recommended that the patient be promptly assisted to the restroom as needed, and as previously stated, have their serum electrolytes checked frequently. Additionally, comfort measures for thirst should be provided while ensuring the patient only has the amount of fluid available based on the fluid restrictions. The patient should be encouraged to use alternatives to oral fluids such as hard sugarless candies and frequent rinsing of the mouth. It is also important to obtain daily weights as ordered and strictly monitor intake and output. Skin turgor and mucous membranes should also be checked for signs of dehydration. Anti-embolism stockings or sequential compression stockings should be applied to prevent venous thromboembolism. Heart and lung sounds should be auscultated frequently for changes, and any adventitious breath sounds should be reported. Neurologic status and changes in the patient's level of consciousness should also be monitored. It is important to watch closely for signs and symptoms of heart failure, which may occur because of fluid overload.
What is Cushing's disease? Cushing's is a disorder that occurs when your body makes too much of the hormone cortisol, or by high dose use of the cortisol-like glucocorticoids over a long period of time. The adrenal glands are responsible for the production of cortisol. Cortisol is sometimes called the stress hormone because it helps your body respond to stress. Cortisol also helps maintain blood pressure, regulate blood glucose, reduce inflammation, and turn food you eat into energy. What is the pathophysiology in regards to Cushing's? When stimulated by ACTH, the adrenal gland secretes cortisol and other steroid hormones. ACTH is produced by the pituitary gland and released into the petrosal venous sinuses in response to stimulation by corticotroponin-releasing hormone, CRH, from the hypothalamus. Signs and symptoms of Cushing syndrome vary. People who have very high levels of cortisol for a long time are likely to have clear signs of the disorder, including weight gain, thin arms and legs, a round face, increased fat around the base of the neck, a fatty hump between the shoulders, easy bruising, wide purple stretch marks, mainly on the abdomen, breasts, hips, and under the arms, and weak muscles. Cushing syndrome can cause health problems such as heart attack and stroke, blood clots in the legs and lungs, infections, bone loss and fractures, high blood pressure, unhealthy cholesterol levels, depression or other mood changes, insulin resistance, and prediabetes. Although Cushing syndrome can usually be cured, it can be fatal if not treated.
A laboratory screening evaluation for Cushing syndrome should be considered in any patient with signs and symptoms of excessive cortisol secretion. The three main tests used to diagnose Cushing syndrome are serum cortisol, urinary cortisol, and low-dose dexamethasone suppression tests. 2 of these 3 tests need to be unequivocally abnormal to diagnose Cushing syndrome. If the results of all 3 tests are normal, the patient likely does not have Cushing syndrome. For these patients, further testing is not recommended unless symptoms progress. If test results are either slightly abnormal or discordant, further testing is recommended. The first test is the serum cortisol levels, which is done by taking a blood sample in the morning and the evening. Normal cortisol levels are usually higher in the early morning and lower in the evening. This variation is lost in patients with Cushing syndrome. The next test is a urinary cortisol test, which requires a 24-hour urine collection. The nurse instructs the patient how to collect and store the specimen. If the results of the urinary cortisol test are 3 times the upper limit of the normal range and one other test is abnormal, Cushing syndrome can be assumed. The third test is an overnight dexamethasone suppression test, which is used to diagnose pituitary and adrenal causes of Cushing syndrome. It can be performed on an outpatient basis. For this test, a low dose of dexamethasone is given orally late in the evening or at bedtime, and a plasma cortisol level is obtained at 8 a.m. the next morning. Suppression of cortisol of more than 5 milligrams per deciliter indicates that the hypothalamic pituitary adrenal axis is not functioning properly. However, stress, obesity, depression, and medications such as anticonvulsant agents, estrogen during pregnancy or as oral medications, and an antibiotic called rifampin can falsely elevate cortisol levels. Your doctor might also recommend other specialized tests that involve measuring cortisol levels before and after using hormone medications to stimulate or suppress cortisol. The saliva test involves analyzing cortisol levels from a small sample of saliva collected late at night. Doctors can see if cortisol levels are too high. Imaging tests such as CT or MRI scans can provide images of your pituitary and adrenal glands to detect abnormalities such as tumors. Petrosal sinus sampling can help determine whether the cause of Cushing syndrome is rooted in the pituitary or somewhere else. For this test, blood samples are taken from the veins that drain the pituitary gland or petrosal sinuses. These tests help your doctor diagnose Cushing syndrome and may help rule out other medical conditions such as polycystic ovary syndrome, a hormone disorder in women with enlarged ovaries. Depression, eating disorders, and alcoholism can also partially mimic Cushing syndrome. Indicators of Cushing syndrome include an increase in serum sodium and blood glucose levels, and a decrease in serum potassium, a reduction in the number of blood eosinophils, and the disappearance of lymphoid tissues. Measurements of plasma and urinary cortisol levels are obtained. Several blood samples may be collected to determine whether the normal diurnal variation in plasma levels is present. This variation is frequently absent in adrenal dysfunction.
Treatment for Cushing syndrome. When Cushing syndrome is caused by a pituitary tumor, the most effective treatment is surgical removal of the tumor. Symptoms of insufficiency may be experienced 12 to 48 hours after surgery, and the patient may have to have temporary hormone replacement therapy until the levels normalize. Radiation of the pituitary gland may also be successful, but it may take months for Cushing symptoms to subside. For unilateral primary adrenal hypertrophy, the removal of the enlarged adrenal gland is the preferred treatment. For Cushing syndrome caused by excessive administration of corticosteroids, the goal is to try to taper down to the minimum dosage necessary to treat the indicated disease process. Therapy may occur on alternate days to allow the adrenal glands to recover and respond to adrenocorticotropic hormone. When the syndrome is caused by an ectopic ACTH secreting tumor, it may be surgically resected, or in some cases, adrenalectomy may be performed laparoscopically. Adrenal enzyme inhibitors are used to treat hyperadrenalism caused by an ectopic ACTH secreting tumor that cannot be removed. Some adrenal enzyme inhibitors commonly used are metirapone, aminoglutathamide, mitotane, and ketoconazole.
Key considerations and interventions for Cushing's disease. In instances where the patient has to undergo surgery, IV glucocorticoids should be administered before and after surgery. This is necessary because if glucocorticoid medications are stopped abruptly, the patient can experience an adrenal crisis, which is a medical emergency that requires immediate treatment. Additionally, a dietitian should be consulted to ensure adequate nutritional intake. Because people with Cushing's disease have elevated cortisol levels, this causes hypokalemia, which is why the patient should be encouraged to consume foods high in potassium. To prevent infection, protective measures such as hand hygiene should be taken. Frequent rest periods should be planned and activities should be clustered to prevent overtaxing the patient. The patient should also be encouraged to verbalize feelings and concerns, especially those related to appearance such as moon face and hirsutism, which is excessive hair growth. Here is her patient education brochure for syndrome of inappropriate antidiuretic hormone secretion. It includes an overview of what the disease process is and what causes it. It also details signs and symptoms of the disease and how SIADH is treated. There are also additional resources provided to get more in-depth information. The website for the Endocrine Society provides information on advancements in treatments of SIADH. SAMSCA is a website about the medication tolvaptan, which is a treatment option for SIADH, and additional information on hyponatremia is provided.
Here's our patient education brochure for Cushing's syndrome. In this brochure, you will find a brief description of Cushing's syndrome along with some of the various causes, the signs and symptoms, diagnostic tests, as well as treatments based on each individual cause of Cushing's syndrome. Also included are some supplemental resources, which includes 2 websites: the National Institute of Diabetes and Digestive and Kidney Diseases, and also the National Organization for Rare Diseases. Both of these resources allow the patient to dig a little deeper into their diagnosis, and they also have information about clinical trials.